Welcome. I'm really happy to be here with you. I heard quite a few comments as people came in, the timing of this lecture, so I don't take that personal. I know some people have to get it done. Doesn't matter who's standing up here, but today it's going to be me. So I hope that I can bring something to this so that you find this enjoyable. I do have a tendency to walk around and call on people. No, not really. So, but I will walk around a bit, and I will do my best to have you participate in your own way. Not necessarily sharing with us all your difficulties in life, but have you sort of go through some of your own potential struggles that we all have had. I will use myself as examples as well throughout these couple of hours, so get ready for some of those. We're going to take a break right at 10 o'clock. I know how important these types of events are, and seeing colleagues and socializing with each other. That's very important, very valuable time to touch base with each other. And I certainly don't want to interfere with that, but we do have to cover these 2 hours so that you have credit for that. So let's get started. So pretty much nothing I am going to talk about today is black or white. There's obvious some black or white, but we're talking a lot today about the gray area. And a lot of people don't realize they have a problem until it's a problem, until somebody else is tapping them on the shoulder. And that's hopefully what we're going to try to address and have you sort of explore yourself. We've all the title is, Why Do I Need This Course? And the reality is, the short answer is we're all vulnerable to boundary crossings, boundary violations, ethical dilemmas that we struggle with at different times in our career, because we're human beings. And our service has to do, our tools are the relationship and our self-awareness and our interactions with our clients. So that's why there's a lot of gray area, because we go through different phases of our own development and our career. The other thing that's unique has to do with the settings that we're in. So, there's quite a few people in this room. I'm going to talk to you. I've chosen the material we'll cover, but that's based on my settings, my experiences in my career. And those are pretty skewed, unfortunately. So a little bit more about my history. For 14 years, I worked at River Oaks Hospital in New Orleans, and that was working with victims of assault or abuse or post-traumatic stress. As an inpatient, we also had outpatient services there. We also work with people with sexual addiction, compulsive behavior, offensive behavior, proclivities, that type of thing. And I was trained in sex therapy too. So just knowing that little bit about me, hopefully you can glean my boundaries are going to be probably different than some of the people in this room, depending on the geographic location, a rural setting versus an urban setting, the inpatient versus outpatient versus community mental health. So there's a huge variation in all of us sitting in this room. And so that, so I have to sort of err on the side of caution and conservative approach to these issues. So the past 11, 12 years, as the introduction informed you, I've mainly been working with professionals and running a program for professionals. And so it's people who have problems in their ability to practice their craft, and it's been brought to the attention of someone, and they're having to address this, or they're going to have some limitations or some sanctions about their ability to practice. So there again, you see the limitations of what I'm about to tell you, because I've seen this end of the spectrum most of my career, and I've had to have boundaries and ethics and guidelines that are over here. So I want you to know that up front about what informs this particular lecture today. All of us, no matter what setting we're in, are expected to understand attachment issues. This is a very popular theory, but what does it really tell us? We know from theory that Our choices in relationships are related to attachment. Our ability to adjust, our own emotional well-being, our sense of self and how we perceive others, like this person is going to behave this way when I'm not with them. So that's a part of attachment, quality in a dyad, and then capacity to transmit these values and morals and connections and relationships to future generations. Whether you have biological children or not, you're responsible for the next generation as a human being generally. So all of this is dictated by our style of connecting with people. Now, that's pretty much a review. But this is what I really wanted to highlight is how in therapy, we're expected to be attachment figures to others in many different ways. Whether you're doing an assessment in the emergency room or an outreach clinic, or whether you're sitting down doing psychoanalytic-oriented psychotherapy with somebody 2 or 3 times a week. The continuum requires us to, at some point, to be attachment figures. So how do we manage that? Well, we want to be dependent and consistent. That's ideally what our expectations are. We want people to be able to express themselves. We want to encourage self-dependency and help-seeking. So we're not the one that people are dependent on. We're encouraging that sense of self-development. We want to be able to promote recognition and connection in people that we work with. We want to be attuned. You know, obviously we want to be aware of people's emotional state and how they're responding. We want to obviously look at their own relationships. We want to interpret the context of their relationships. We want to be aware of these counter and transferential issues. We want to help people develop the capacity to experience tolerance, not to just constantly expect us to take away any pain, but to help them experience tolerance. So all of this, essentially, is exhausting, right? So that's why when you come to conferences like this, you love to have extra long breaks, because you get to chat with people. And part of chatting with other people are that you essentially in your career, you go around a lot of times with a lot of this information by yourself. How many people in this room, unless you're in a relationship with someone that does the same thing as you, in your important relationships around you, know what those people know what you do day in and day out? Raise your hand. All right, so they know what you do. They know exactly what you do each and every moment during the course of the day related to what your interactions are with other people. Most people don't. I mean, I've been married a long time. My wife doesn't know what I do, okay? She knows a little bit about what I do, but she really doesn't know what I do. And so you're expected to have these relationships, have these connections, be that figure for people. And a lot of it has to do with getting support. You don't have to go, at this break that we're going to have, you're not going to have to explain to somebody what the heck you do for a living, right? Like if you're somewhere and you're trying to say, how do I say it? How do I not say it? Do I really want to tell them? Do I really want to hear their problems? Whatever it is that we say at social functions. So you get to cut through that when you come to educational opportunities like this, and you get to have quicker conversations with people who do the same thing. So all of this leads itself to the idea of we're giving a part of ourselves in the course of our profession. And we've chosen this profession. And there's often, we're receptacles in a lot of ways. We got to hear, we got to experience, we got to have a lot of emotional connections, and then we have to sort of experience that. And this isn't exactly the right description, but there's a lot of suffering in silence. You don't really get to share with other people what you're going through a lot of the times. You can't. You wouldn't be able to do your job. You'd be constantly in supervision, all right? You have to be able to deal with this on your own. All right, so You live in a small community. By the way, I find your community to be very lovely here. I'm a native New Orleanian. I still live in New Orleans. I travel back and forth to Hattiesburg. We have a rich history, as most people probably know. It's a little different than Williamsburg here. But what's that? Brett Favre, okay. So that's Hattiesburg. That's Hattiesburg. Yeah. So I drive back and forth to Hattiesburg. I live in New Orleans. But we have a rich history in Hattiesburg, too. So let's get to this guy or gal. You live in a small community. You see a couple for domestic violence. She's a nurse. He's a police officer. The couple is doing good therapeutic work, but there's still ongoing work to be done, and they've agreed to continue working on this issue. One morning, you're running late for whatever, you fill in the blank, and you're stopped for speeding by your local law enforcement. The officer turns out to be your client and immediately refuses to write you a ticket saying, quote, "I am so appreciative of how helpful you've been to me and my wife." What do you do? Thank you. Thank you. Thank you. This is awesome. I didn't ask for that. All right. Anybody else have anything other than thank you? Thank you very much. Some people may say, well, is it a state ticket or a local ticket? Because I can get a local one fixed or something. It's a gift. It's a form of a gift. So your comment is, maybe I shouldn't be doing this because this is a form of a gift. So, all right, so this comment is, I know that I really need you to write me this ticket. I appreciate that, but I need you to write me this ticket. All right.
I'd probably say don't let our professional, our therapeutic relationship have any bearing on what you do in this matter. So treat me just like you would any other person you pull over.
All right. So treat me just like you would any other person. And you know all this is being recorded, right? Because people walk, not this. Even though I got double mics, I feel really important up here, you know. I guess it's like in case the lights go out, the other one will work or something like that. But so, I'm saying recorded. Why did you pull me over anyway? You knew what kind of car I drove. All right. Yeah. Uh-huh. So, all right, so he's given a warning. Is there something therapeutic for him to say that? Excellent.
You're seeing a couple for counseling, and you might be inclined, or he might expect you're inclined to align with him if he does you a favor.
Okay.
And it's already a domestic violence issue, and we really don't know the layers of that.
Very interesting. So you're seeing a couple here, and the comment is that you're somewhat aligning with this person by accepting this type of action on their part. Interesting. Any other thoughts? See, it's not clear. It's not clean here. All right? There's a number of different consequences. No matter what you do, there's a number of different consequences in this scenario. All right? So if you say, I want a ticket, you must give me a ticket. You cannot give me a gift. I cannot accept gifts. All right? There's some consequences for that. If you say, thank you very much, there's some consequences for that. If you look at it as a couple, there's some consequences for that. It's just continuously. This is a situation, dual relationship, which we'll talk about later, but nonetheless, here's an example of how there's a lot of gray area and how you respond. Now, what if, 3 months later, you're expected to write a letter to the judge about their progress? Might there be some expectations? So, some quid pro quo, I did something for you. What if you're not thinking that they're ready to move on? So, just some thoughts. So, Mark Twain said, to be noble is good. To tell others how to be good is even nobler and a lot less trouble. So a lot of us, every single one of us in this room, saw that scenario. We saw the brave people who spoke out, who chose to say, oh, this is what I would do. It was easy to do it as a group. Thank you very much. Everybody did that one. But then the individual people that stood out and said their opinions about things, we have to watch judging those because we're all, have to make these decisions. We all have to make these decisions. And to think, well, I wouldn't do it that way. In some subtle way, I think that's why reality TV is so popular, is that we get to see somebody else's emotions. They capture that emotion in the moment. And we get to say, well, I wouldn't have done it that way. I would have done it different. So Mark Twain had some wisdom when we like to think other people need to do things different because it makes us feel better. So just be conscientious how we judge other people. Now, I'm not saying when the newsletter comes out quarterly that you can't go to it and look at who's gotten in trouble with the board and what they did to get in trouble with the board, or look online and those types of things. Because you should, be reminded of your expectations and what's happening. All right, here's another one. You're in recovery. You have been attending the same 12-step meeting for a long time. Just recently, you've been seeing a patient who has not been going to 12-step meetings, but has attended meetings in the past. He does not know you are in recovery, nor have you ever seen him at meetings. You're having some struggles and decide to share at a meeting. At the meeting, you see your patient. What do? It's real quiet right now, huh? This is a tough one. What do? Common decisions. What'd somebody say? Keep your mouth shut and talk to your sponsor afterwards. That could be a choice, yeah?
I'm actually in recovery, and I've been in this situation quite a bit. And
Uh-huh.
If I feel the need to share, a lot of times what I'll do is I'll share in very, very general ways.
Uh-huh.
And then I do talk to other people, after the meeting.
Mm-hmm. So you temper your sharing in the meeting, and then you get your needs met with other people outside of that meeting. Okay?
On the flip side, though, you being at that meeting with him may cause your client not to share.
That's a possibility. It could easily flip. Excellent.
It could also benefit.
It could benefit, definitely.
There are meetings for professionals.
Uh-huh.
You are a professional and you're free to access to.
Right.
You would not go to a regular meeting because everybody there would be your client, obviously.
Sure. So you may use some measure of judgment about which meetings you attend.
There are many meetings for professionals.
So there are some meetings that professionals can attend that are exclusive to them. Good. So that's an option, or that could be your approach if that's what you choose. Yeah.
It's similar, it's not the same thing. But I have lived in small towns and moved here recently, so I have lived in a small town. And this is a small enough town that you run into people outside. So does that mean that every time you run into a person, you have to do something? I actually preface it, I'm in private practice, so I preface it, especially if I'm working with somebody in recovery, saying, I have been in recovery, or I live in this town,
Right.
and if I see you, it's up to you to make the decision as to whether or not you want to say something to me. Because to me, this is a scenario that can be seen whether you're in a 12-step meeting or anywhere.
Right. Excellent. So the comment is informing people ahead of time of how you will react to them, what they can expect of you outside of the office. Okay? So you can avoid. Some of these situations and scenarios are completely unavoidable. But if you have a way to tell people ahead of time, I want you to know that If I see you in public, I may not approach you. I don't feel like, you need to explain to people our relationship, or the people I'm with, I need to explain to them our relationship. So I want you to know that ahead of time. And then, the other thing about the previous scenario too is when you get back, when you re-engage with that person, you need to explore what took place. So if the police officer, that very next session, the very first thing that needs to be talked about is what happened in between and how you had that encounter and the speeding ticket incident and that type of thing. That's what you were going to say, yeah. So definitely telling people and communicating these things ahead of time are essential.
I got one comment on this too, what I do, and I'm in the recovery community here in Williamsburg, plus a therapist here, and what I've had to do is set boundaries not only with patients and former patients, but also members of the local 12-step community. Because my patients know I'm in recovery, and the people in the 12-step community know I'm a counselor here.
Yeah.
So I have to set boundaries with both sets to say, if I'm at a meeting, I'm at a meeting because I
Right.
need to be at a meeting. And I'm not here to deal with anybody you're sponsoring or anything like that. On the flip side, and with the patients or former patients there, that I'm not there to conduct therapy with them.
Right.
And on the flip side, they know that, all that is talked about, well in advance. Again, it's like I'm informing you this is part of who I am and what I am. But equally, and it's even become more challenging, is actually the members of the 12-step community, because they're upset that
Right.
they
want some therapy.
Sponsees are not.
They want therapy. They want some therapy.
Aren't doing what they're supposed to be doing. And
Yeah.
want me to intervene.
I actually live an hour up the road. I live in Richmond, and I run into the same thing as
Yeah.
well. And because there are people that leave here that go to sober living that's in Richmond.
Right.
And some people know the meetings that they see me at a meeting and they assume, that I go there all the time, and I do. But I have to set that boundary with them that I don't really necessarily need a rundown of everything that's working or not working, and I'm here because I need to be here. And they
Yep.
respect that. They don't
Right. So
cross that.
there are really two boundaries that take place in a therapeutic relationship. There's one that you create about your experience, and it's obvious in these settings, in this setting, you're going to be bringing the setting outside of your office, outside of your facility, outside of your organization, because a lot of people are expecting therapeutic interventions at these meetings, or if they call you in the evening, or some, family. I got a friend of a family, so your boundaries are stretched outside of the office. But then you have a boundary too with the person directly. Yeah, one more comment. Yeah.
All I was going to say is, to me, that's part of informed consent.
Yes, part of informed consent. Excellent. We're going to cover this stuff, but I just try to trick you at the beginning, right? I got to get you going. This is probably one of the better articles I've come across, and it has to do with the process we go through when we make decisions about boundaries with people. And it posed these 18 scenarios, and then it's very similar to what we just saw, but they're a little bit shorter. And then it assessed people on these 4 different dimensions. And the dimensions are, what is your knowledge base of your ethics? So how many people in this room in the last 6 months to a year have read their code of ethics? And not a lot of us. I haven't done it. Let me take my hand down. I was doing it for demonstration purposes. So these are not things that we readily just plow through. I've read part of them for some different things, but not in its entirety. So our knowledge base has to really constantly be updated. That's why you're required to take these courses every few years. I heard somebody say it's every 3 years. Louisiana and Mississippi is like every year or every 2 years that you have to do 3 hours. Yeah. So, you're expected to keep up to date with some of this. So the knowledge base, what is a knowledge? Did you know this was an appropriate boundary? Did you know? So that's the knowledge part. The second thing has to do with how comfortable are you with this? And, can you say to someone, I really don't allow gifts, or, you didn't show up for your appointment, so you're still being charged because that's our policy. or when you're out in public, you just don't acknowledge them. You know, can you do these things? How comfortable are you doing these things? That's the second thing. A lot of it comes from experience. Have you experienced this before? I still get things that I think, oh, I don't have a problem, and sure enough, I have a problem with it. So, give you an example. So, from New Orleans, I don't know if you knew this, but the Saints went to the Super Bowl a few years back. So I get to go to the Super Bowl. I'm fortunate. I come back to work, and it's a Tuesday. With you got a lanyard. You stuff your ticket in there, and they gave you a little pin, and they said I was there, and had the Roman numerals like the Super Bowl. So here I come Tuesday in my coat, got my pin there, and walk into work, and my colleagues are like, nice to see you. You're not wearing that, right? I was like, what are you talking about? Are you kidding me? The Saints won the Super Bowl. Did you see that like 2 days ago? Yeah, I understand. You're not wearing that pin, right? So they just repeated it like a broken record to me, and I told them it was too bad. I was wearing this pin because they were on a different planet from me. And sure enough, I go into with all the patients, and that's the topic of the day. They're continuously asking me questions, and I can't back out of some of this because I brought it on myself. Now that's just one example. We're continuously needing more and more experience to manage some of these boundary issues. And then obviously the process of making a decision. How do you go about doing that? And we'll go through that here. All right, so after about 35 minutes, we're finally to the goals here and what we're going to accomplish. Oh, this thing jumped around. All right. Yeah, we don't need to go over the goals. We know what they are. So this is where you get to participate, okay? So I'm going to ask you about 25 questions, and I want you to have a little piece of paper. I want you to write it down in private here. And each time I ask a question, I want you to put an N for never, an R for rarely, an S for sometimes, and an O for often. All right. First question. I have told patients personal things about myself in order to impress them. I have told patients personal things about myself in order to impress them. Number 2, I have accepted social invitations from particular patients outside of scheduled clinic visits. Number 2, I've accepted social invitations from particular patients outside of scheduled clinic visits. Number 3, I have used language other than clinical language to discuss my patient's physical appearance or behaviors I may consider seductive. I have used language other than clinical language to discuss my patient's physical appearance or behaviors I may consider seductive. Number 4, I have found myself comparing the gratifying qualities I observe in a patient with the less gratifying qualities in my significant other. Number 4, I found myself comparing the gratifying qualities I observe in a patient with the less gratifying qualities in my significant other. Number 5, I have thought that my patient's problems would be helped if he or she had a romantic involvement with me. I'll read that one once. All right. So, let's go to the first one here. Just just score yourself. I mean, put your own. We're going to go through 25 of these, okay? So just hold on to your thoughts. Don't change your answers after we discuss them, okay? All right. I've told patients personal things about myself in order to impress them. What's wrong with that? I mean, didn't the staff, introduce me and tell you, I teach at a university, and didn't I tell you some of my clinical experience? Haven't I told you I'm from New Orleans? Haven't I told you I went to the Super Bowl? Don't you think I'm just trying to impress you? You're not my patient. That's one good thing.
Is establishing credibility the same thing as...
All right. So is establishing credibility the same as trying to impress people? Or joining with people? Yeah.
There's already a power differential between the
Yep.
therapist and the client.
So there's a power differential between a therapist and a client. You have to be careful of that. Yeah? It's not about you. Perfect. Any other thoughts?
I think there are times when it's appropriate, when it's to share personal things, but my intention is not to impress the client.
Right.
It's for bonding or to reinforce the point.
Right. So there's times where you may share things, but it's not to impress people. The intention is different. Yeah.
Informing the client about your professional qualifications is not the same as personal information.
Okay.
It's recommended that you let them know what your credentials are.
Sure. So it's recommended you let them know your credentials. You're not really trying to impress them personally. All right. Good. Good comments. Excellent discussion. So what I do is I have a handful of items that I will share about myself. Maybe 7, maybe 8. If I start to get outside of those, I have to ask myself, what am I doing? Why am I doing this? What is going on with me that I am sharing some of this material with someone? And it has a tendency to happen when you get more casual with the relationship, more relaxed. So maybe even during the termination phase of a relationship, when you start to say, well, I don't have to keep this up. I don't have to keep this relationship up because the person we're terminating. So think about it that way. When you start to get outside of those items that you pre-select, that you're willing to share with people. The other thing is, don't be willing to share some of it with this group, but then share something different with this group of people. That's not okay. It needs to be universal. Because that starts creating selective memory, and that implies that you're wanting to do something different with certain people. Now, again, there's a lot of gray area, but I'm just giving you some ideas, some suggestions. What about social invitations for particular patients outside of scheduled clinic visits? You know, I work with adolescents, and they graduated from a VOTEC school, and they sent me an invitation, asked me if I would come to the graduation ceremony because I meant so much to them. Or, you know, one of my patients' children is having a bar mitzvah, and I'm invited to that. Or somebody's died, family member has died of a patient, or even a patient may have died, and so I go to their service. These are all social invitations. Yes. These are tricky. So would you, if you've gone to, did you say you said you went to one?
I did.
You did. Okay. So,
Clients.
all right. So you go to that one. Have you been to every other one since? You go to every one?
I know that it's not.
Every client. So that's fine. That's yours. If you can somehow tie that in to the treatment, the expectation, what you were doing, you're willing to write it down, you're willing to document it, that's another issue. You have to watch a little bit with confidentiality, but you know, if that's something you choose to do, that's part of your practice, that's part of your area, and you know, that's what the norm is, that's what the expectation is, and that's what you're doing. Yeah.
I was not understanding when you said social invitation or social occasions, like that it was, if you're talking about like something that would be like a marker event for the client that they invite you to because they feel like it benefits them for you to be there. I wasn't thinking of that in the same way as if like I got 2 tickets to the Super Bowl, if you want to come and be
Right.
a guest.
Right. Yeah, there's a little difference. There's a little difference, but not much. It is social. It's in public. It's asking about bringing the relationship out in public. And so my quick rule of thumb is be willing to write it down. Don't do or say anything unless you're willing to write it in a chart. So if you chose to go make a visit to the hospital for somebody who had a tragic accident or something like that, even though that's not necessarily social, it is public. Remember, I said the boundaries of the therapeutic relationship as well as the boundaries individually. Yeah.
I think one of the key pieces that you said to that when you were just talking was that you have to be willing to do it for all the clients. You know, that kind of sets the ethical standard, you know, that it's, you're not playing favoritism or
Right.
the boundary. Like she said that she does it for, you know, for clients, but you'd have to keep it therapeutic. You know, like if they asked you and there was a process or that you were going to go and help them get through that.
Mm-hmm.
You know,
Yeah.
I think it's, as they talk to it.
It's universal. A lot of these are universal. Are you willing to do them universally? Good. I've used clinical language. I use language other than clinical language to discuss my patient's physical appearance or behaviors I may consider seductive.
Are we talking to the client or are we staffing?
Staff. This is to other staff. This isn't to the patient. This is to other staff. Okay, so this has to do with the language we are choosing to communicate to others about people we're working with. The more casual, the more relaxed our language, the more aware we need to be about our boundaries with that person. And if we're doing something descriptive about their what we imply that is seductive, we believe or interpreting as that, which is a natural process. People are attracted to you. They like that, you know, you're coming to them. You're generally a figure of authority with wisdom and knowledge. You seem to have your stuff together, so to speak. So they're longing for you. They have to put that faith in you, that hope in you. That's normal. Okay? So some people communicate through seductive interactions. So then that's one thing you have to define. Is this seductive behavior? But the key is the language. This is the one that's more important. What is the language? The farther away you actually physically get from the location of your employment, the higher the likelihood of you breaching confidentiality and also using more casual language to describe your interactions.
This also stands like if you have an office environment and you're going downstairs and talking about your client, even if they're not sexual,
Yes.
but you're describing them as maybe they're real pain.
Right.
They're all of that.
Right.
It's the same thing.
That's right. So it's gossip. Gossip is basically impossible to defend. All right. Having a consultation in the hallway is a lot different than gossiping about a person. Good. Number 4, I've found myself comparing the gratifying qualities I observe in a patient with the less gratifying qualities in my significant other. Wait a minute. All right. The tools that we use are our relationships with people. Okay? That is the tool, our relationship with people. So, excuse me, I bumped into you. That is part of it. So, you're going to tell me there's not people that are attractive that you've worked with? Not just physical, intellectual, their creativity is off the charts. Maybe just their energy. Maybe they seem that they draw people to them. Maybe their ability to manage certain areas of their life or other parts are just incredible. Or they're talented in many different ways. So we cannot find, patients attractive. How many people believe that? You should never find patients attractive. Good. Because that is a natural human interaction. But the question here is, what about comparing what they have or what they're doing to what you have back at home or in your own life? How do you do that? I mean, hey, that's a pretty nice Valentine's gift there to draw that bubble bath for your partner. I wish my significant other would have done that, or brought me some flowers, or thought about me, or sent me a text or something like that. Yeah. So if you share this with them, you may get some response. That would not be suggested, okay? Yeah, unless it was one of your 7 things you're going to share. But yeah, so be conscientious about what you're sharing with someone else. But this is important because obviously this is a signal, meaning you might need some supervision, you might need some consultation, you may even need to refer somebody. All right, number 5. I thought well, that one's pretty straightforward. You're not supposed to have relationships with your patients. Okay, so ultimately what we're trying to get at here is doing good, not doing harm, allowing people to have choices, being fair and equitable, and being loyal, showing up, doing what we're saying we're going to do. So there's a morality of doing the right thing. We all have this. They're based in this, and they're enforceable by our code of ethics and our code of conduct. And that's part of whatever licensing board, body you have, substance abuse, psychiatry, all of them, they all have the same. You have some code of ethics. Man, this thing's jumping around. This is just more of what the expectations are, that we're expected to do service, justice, with dignity, find worth, relationship, do it with integrity. What you see is what you get. By now, I've been walking around here for 45 minutes. What you see is what you get, all right? I'm not like somebody outside of here that's not the person you see today. I behave the same exact way. Now, if I try to, like tonight, go home at the dinner table, which I'll get home too late for dinner, but anyway, if I try to pontificate like I'm trying to be creative in my words here right now, I'll get kicked in the shin. And somebody say, hey, man, what the hell are you talking about? Come back down to earth. But at the core, what you see is what you get. And that's pretty much what we all have to strive to be there. Man, that thing is fast. All right, well, this is just more clear definition about the principles of making decisions, okay? And how this is the incubator that we're expected to foster in making decisions about ethics. So we're expected to serve the patient's needs, not our own needs, like the comment in the back. It's not all about us. And boundaries increase the likelihood of independence. That's really important, that we want people dependent, or we want people to be independent. We're expected to do good, no harm, if there's conflicts of interest, to resolve those in a responsible fashion. So if somebody keeps bringing us bell peppers every time they come to our appointment, and they're leaving them there, and we don't really have a policy in our office, we're throwing them in a garbage can, whatever it is, then we're expected to try to resolve that with someone. We're expected to guard against personal, financial, social, organizational, political factors that may lead to the misuse of this individual relationship. Trust. Our relationships are based on trust. I say what I'm going to do, I do what I'm going to say, follow through with that. We broadly refer to rights and responsibility, but all of us have some policy and procedure that we give people so that they can know. We need to give them a copy, and as well as us retaining a copy of this. And then we do what we say we're going to do. Now, this is from the Federation of State Medical Boards, but most disciplinary actions are for lack of professional behavior. All right, we'll do our next 5, and then we'll take a break. Number 6, I found myself trying to influence other employees in my workplace over whom I have supervisory influence to support political causes or positions in which I have personal interests. Number 6, I found myself trying to influence other employees in my workplace over whom I have supervisory influence to support political causes or positions in which I have personal interest. Number 7, I have felt a sense of excitement or longing when I think of a patient or anticipate his or her visit. I have felt the sense of excitement or longing when I think of a patient or anticipate his or her visit. Number 8, I have found myself talking about my personal life or problems with the patient and expecting sympathy. I found myself talking about my personal life or problems with the patient and expected sympathy. Number 9, when a patient is acting in a manner I consider seductive, I experience this as a gratifying sign of my own sex appeal. Number 9, when a patient has acted in a manner I consider seductive, I experience this as a gratifying sign of my own sex appeal. Number 10, I have engaged in a personal relationship with a patient either while I was treating him or her or after treatment was terminated. All right, you got all your answers, right? No erasing. All right, number 6, we're going to review this one. Trying to influence other employees in my workplace over whom I have supervisory influence to support political causes or positions which have a personal interest. All right? How many people bring candy to work and try to sell it for their children? How many people are asked to donate to the United Way or something in their organization? All right? These things aren't like way out there. They exist. Now this is moving things more to, do you do it often? That's a little different than rarely. But the point is, don't just say, that doesn't apply to me. And the issue here is looking at coworkers. So notice how there's a transformation that takes place in this item. It's not just patients or clients that you have to be cognizant of, but it's also your peers. Been a victim of that. All right. Well, that's good that you're recognizing that. And I'm sorry. Wow. Right. Right. So the expectation was to make a donation. Or to be held against you. There are some ways that people manage offices sometimes or other, political type events that affect others. So I felt a sense of excitement or longing when I think of a patient or anticipate his or her visit. Come on. We don't have any easy patients. Oh, I can't wait to see Mr. and Mrs. Jones or little Johnny or little Susie. They're so great. They do their homework. This is an easy case. And this is a little bit different, anticipating and longing. The key word here is longing. That's a little tricky there. I found myself talking about my personal life or problems with the patient and expected sympathy. Yeah.
I had a situation where I had an emergency surgery.
Yeah.
And then I had a second surgery, and then I was put on bed rest, 2 surgeries and bed rest, all in 6 weeks' time.
There you go. So you have an emergent medical condition. So obviously it's going to have to be communicated that you're out.
And having to come back and try to explain that without sharing, but explaining why I wasn't available and present.
That's right. So explaining why you weren't available and present, and it's bad enough you got to recover physically, but now you got to sort of make this adjustment. Hey, we chose this. All right? We're the ones. We've chosen this field. There are limitations. There are consequences for us choosing this field. I know we don't like to think about that, but there are. Good example.
Out sick didn't work.
Out sick didn't work for 6 weeks, huh? Yeah.
Wasn't there a add-on there that said to elicit sympathy?
No, expecting sympathy. All right.
To me, that's where it crosses the line.
All right. Well, let me ask you this. It's a good statement. I agree with you. But let me ask you. So, no. So somebody's going to go through a medical procedure that you've been through, or somebody's child is having a procedure that your child has, same disease or a procedure or something. Do you share that with them?
Well, again, I think check my motivation.
Okay.
So why am I sharing this? Am I
Right.
sharing this to sort of say, oh, for me, and have them somehow have empathy for me, or am I sharing because to lend support or
Right.
maybe normalize it? But again, if the focus is on them
Right.
and their experience, and I think that's okay.
Okay.
But if I'm trying to pull them into feeling some kind of sorrow or sympathy for me, I think that's not okay.
Right. Right. So we wouldn't say, oh, it's no big deal. My child had the same thing. You'll be fine. That wouldn't be good.
Well, she just reminded me of, way back when I was training to be a mental health therapist. And it was when we were practicing Montessori, and you're absolutely right. Peel away the onion skin to see what's really motivating you.
Yes.
And that's the only way to do it, because on the surface you might think, oh, it'll make them feel better, but it's really me. And, I don't even think they teach a lot of psychoanalytic theory anymore. But most times if you stop and you peel away,
Yeah.
then you can find, but only when you do that. That's right.
So I might not do it right away until I have a chance. The impulse might be to say what you just
Right.
said.
Right.
But the challenge for me anyway is to create that space to ask myself and explore with myself, why am I doing that? And sometimes the moment's lost.
Yes. Excellent. So being able to create that pause. Okay, so one of my favorite authors of late is Malcolm Gladwell. And he's written a number of books, The Tipping Point, Blink, Outliers, all these things, Wag the Dog or something like that, The Tail of the Dog or something. But the Blink book says, hey, if you have a thought, honor that thought, because there's probably some validity, some truth in that thought, some truth in your observation of an interaction. He's telling the public to do this. So as therapists, we really should have that skill to be able to do that, to pause and say, do I need to do this? What is my motivation? What is the anticipated outcome? That's called meta-communication, where we're constantly looking down on ourselves and how we're interacting. You had a comment?
I think that whether, like in the case of, like if they're
Medical?
out for 6 weeks,
Yeah.
I had something not for that long, but a procedure and had to be out, and ended up telling clients a brief thing about why.
Yeah, sure.
And not that I was expecting sympathy, but whether you get an empathetic reaction from the client is instructive.
Right.
A little bit about your relationship with them and about kind of where they're coming from in some ways. So it's not looking for it, but it's interesting to see what you get and don't get
Right.
in the relationship with them.
So you're using it. You have to have access to it, and you have to use it. Absolutely, 100%. Good. Yes. How you define sympathy.
It's not necessarily, for you, but like in my situation, it was, I was hoping that they would understand,
Sure.
kind of my absence and kind of not hold it against me. And there was
Right.
one client that did, like, how dare you be gone?
That's right. How dare you be gone was one of the client's responses. Yeah. Excellent. Yeah, this is worth exploring. There's a lot of issues that come up. All right, two more. When a patient's act is seductive, I experience this as a gratifying sign of my own sex appeal. Well, you are an individual. You do have sensuality and sexuality. It's not uncommon that people may find this appealing. Okay? The key here is that you're attributing this process to your sex appeal. That's where you have to start considering, is that an appropriate assessment of what's going on here. All right, the last one. This is engaging in a personal relationship before or after treatment was terminated. We all know that there's guidelines around relationships and time frames. Again, being of the more conservative era, it's a lifetime for me that I've chosen, but that's me. Different people have different expectations. I had to turn the mic off for a second because I have a video I want to show. It's a very short clip, and I think it illustrates what we've been talking about. It's from a movie called Lovesick, and so I have it turned up a little bit. There's one short scene I want to show you. Dudley Moore plays a psychiatrist, and his friend Otto is a colleague psychiatrist. All right, let's just turn this down. Is that okay? Can you guys hear me? So it wasn't the best video quality in the sound, but the point is a lot of what we've already spoken about was illustrated right there in that video. Somebody having thoughts, somebody being attracted to a patient, sharing information, gets farther away, talks about some of the specifics that they're having, they're experiencing. It's really, you know, Hollywood has not done a good job with respecting therapists' patient boundaries over the years, and it does the same in this, and that Dudley Moore eventually, you know, as just the name of the movie, Lovesick. There's no love involved when there's therapist, doctor in this case, patient. It's a violation. But, Hollywood does things a little different. But just wanted to point that out and just show you a little clip of that. Any thoughts about that? Anything anybody saw that they thought was kind of interesting? If you could hear it at all? I think for he's a jolly good fellow and all that stuff was said. And so that's when his guilt got to him, and he said, I need a consult. And he goes in there and tells how horrible he is. Yeah.
I like the comment when he says, you're an ethical man, and he goes, not in my mind.
Yeah. So I'm an ethical man, but not in my mind. So that begs us to say, what about when we have thoughts and ideas? And what do we do with those? And how much are we entertaining those? And are we seeking out assistance? That was a consultation. He encouraged him to refer. And what do you mean? You kidding me? Refer this patient? The ultimate referral actually takes place because Dudley Moore is about to get a phone call that he's dead. And so he takes the case. Dudley Moore takes the case. And Sigmund Freud makes a few appearances. But all right. I'm not going to go back. We're going to move forward here. I'm not going to keep trying to go back here. But this is Guttel, Gabbard have done some sentinel work in the early 90s, and he's continued to build on it. So the latest book was written in 2011. It says Preventing Boundary Violations in a Clinical Practice, and Guttel is the author of that. So if you want some of the later works that are done, there's a few journal articles out there, but books are a little bit easier and quicker. But there are chapters on all of these items right here, full chapters that discuss them in great detail. So we're not going to be able to go over them completely, but I just wanted to point out a few things. So how you spend your time, and do you allow things to go over? Do you allow things to start late? That's an important boundary to communicate. The role. Your role as a professional, your role as a clinician, your role as a therapist is very important. So I mentioned to you earlier my role. So I'm in the role right now of an educator. If I was being in a therapeutic role, I would try to engage a little more, be more empathetic, listen a little more, not talk as much as I'm talking. So there are different roles that we have. Well, there needs to be boundaries around those roles. The place, our environment, and how we set up our office, the things that we put in our office. It tells a lot about us, the way we dress. That's all disclosing information about us without necessarily sharing those 7 to 10 things. But our place will also disclose some of this. So making sure it's a professional place there. Gifts and how you handle gifts. Depending on what your policy is, what your office policy is, what your organization, institution is. Do you disperse them amongst the staff? Do you use it as an opportunity to have a conversation? When I was doing my graduate studies, I did my internship for 1 year at the medical school in New Orleans, and I was able to have year-long psychotherapy patients. And so at the end of that, I had one patient give me a book. And the book was 1,001 Questions. That was the title of the book. And so I used that as an opportunity to have a conversation about how I knew all this stuff about him. He didn't know too much about me. So that was one of the things. It was a psychoanalytic-oriented field placement. So that was part of it. Also, it could be a little bit of his anger towards me about, he's had to answer all these questions. Now you need to answer these questions. Or he could be saying, you're just a student. You still have a lot to learn, whatever. There's all kinds of possibilities. But interpreting the gift is helpful. The other gift that I got that year is, it was back when you had these organizers. They weren't electronic. And I got a female patient who I worked with, her and her daughter, divorced. She gave me this planner, and it was for the upcoming year. And so I used that as an opportunity to have a conversation about, she wanted to be in my life every day the next year. It was like a reminder that, every time I would open this thing, I'd say, oh, so-and-so gave it to me. So gifts are important. The value of the gift, the meaning of the gift, It's just opportunities to explore the relationship and how, termination in a couple of those cases were part of it. Physical touch, how are you going to be with touch? Where are you going to touch people? Are you going to communicate that with people? What are your boundaries around touch? Essentially, our touch boundaries are, from the knees to the neck are usually off limits, our face and our buttocks. We don't walk up to somebody, yeah, nice to meet you, or, have you been down to the, the GOB, or, the street down, the BOG or something like that down the street, the boulevard of something like that. Dog Street, something, DOG, all right. I get these acronyms right. All right. So anyway, you don't like introduce yourself, touch people on the face. Those are some touch boundaries. Money, hey, this is a fiduciary relationship. The expectation is that there's a financial exchange. And are you forgiving people their balance? Are you allowing them to not pay you? That could harbor some anger, could harbor a little resentment that you have that's unspoken. So to get that out and communicate that. I already mentioned a little bit about the language you use, cultural issues, geographic issues. These are all variables to bring in to understand what your boundaries are and try to clarify how are you going to manage these. Now, there's Guttel and Gabbard's sentinel work there. All right. There are two things about boundaries and problems. One is related to boundary crossings. The other one is boundary violations. These are two separate things. So how many people in the room have committed boundary crossings? Raise your hand. All of us should raise our hands because we've all done it. All right? While they're not necessarily a part of the treatment or harmful, you need to pay attention to them and how they're affecting the relationship. Violations are harmful and exploitive, and that's what you lose your license over and you get sanctioned for. So these are, the crossings are elusive, harder to define, can be harmful, benign. Inevitably, they can be acceptable, but not necessarily always. So it could be loaning a book or accepting a gift or disclosure. These are subtle types of crossings. All right, back to our test. We got to make sure you get this done so you know your score at the end of the day. Number 11. I think about what it would be like to be sexually involved with a patient. I think about what it would be like to be sexually involved with a patient. Number 12, I've initiated or engaged in a personal relationship with an employee that I supervise. I've initiated or engaged in a personal relationship with an employee that I supervise. Number 13, I take great pride in the fact that such an attractive, wealthy, powerful, or important patient is seeking my help. I take great pride in the fact that such an attractive, wealthy, powerful, or important patient is seeking my help. Number 14, I found myself talking about my personal life or problems with patients. Kind of covered that one. 15, I have resisted or refused consultation with appropriate professionals when others have told me that I have problems that cause difficulties in my work or personal relationships. Number 15, I'm going to repeat it. I have resisted or refused consultation with appropriate professionals when others have told me that I have problems that cause difficulty in my work or personal life, relationships, sorry. I'm going to continue. Number 16, I've initiated or engaged in a personal relationship, person who I have power, authority, decision-making. That's a repeat. 17, I've asked one or more patients to do personal favors for me. Drop the mail off, pick up my cleaners. Number 18, I found myself trying to influence my patients to support causes, business deals, or positions which have a personal interest. I also own this ballet studio. You sure your kids don't want to take ballet? I've initiated business deals with patients. That's number 19. And then number 20, I have solicited gifts, bequests, or favors from patients for personal benefit or the benefit of business which I am or plan to be involved. So solicited gifts, bequests, or favors from patients for personal benefit or to benefit a business, which I hope to. We're not going to talk about those. We don't have time. We're going to get to the end of them in a minute. So some of the boundary crossings are minor deviations from traditional treatment. They may enhance the relationship. They're benign departures. They need to have a purpose. That's what we were talking about earlier. What's the purpose? What's the function? What's the motivation? What's the intent? Do you have those questions answered? Sometimes the value of a gift, so sometimes it would harm a relationship more if you reject the gift than if you accept the gift. So you need to consider those things. Violations are exploitive financially, psychologically. I've worked with across the whole gamut. People who have scounded money from people through investments, and financially, obviously psychologically, and sexual boundary issues. They're serving the practitioner's desire. They're not in the service of the patient. When boundary violations, people do commit boundary violations, they affect a lot of systems. So it's not just the ethics of your profession. If you were in this organization, your organization is affected. The reputation of the organization is impacted. And not only that, all the other professionals who are of that profession are affected. We're all affected when people have boundary violations. So what are some guidelines? Come on in. This has to do with dual relationships. We basically, in relationships, we have a biological, instinctual interest in socializing. There's societal and cultural scripts that we subscribe to. We have experience in relationships, and then we have awareness. So what about doing addiction work? What are some of the risks? Well, it's usually higher in this domain because you have people with a lot more history themselves that may be interested in carrying the message, practicing the 12 steps, being involved in meetings. How much do I self-disclose? So these are all questions that can be answered. There's recently the National Association of Addiction Treatment Providers came out with some ethical guidelines about 3 months ago. They don't talk specific about disclosure, but they do say in general about the well-being of patients and not exploiting patients. So, the old story about the merchant who's traveling across the desert and pitches a tent for the night and finds that that was kind of the only tent that I could come up with. I know it's kind of fancy for one person, but got a camel there. Anyway, sleeping in the night, and about 12 o'clock, the camel sticks his nose in the tent and says, "Is there any way I could just keep my nose right here? It's really cold out here. I'll really be fine if I just have my nose right here." "Oh, that's fine. Leave me alone. I'm sleeping." So about 2 hours later, "Can I stick my head in this tent? My ears are really cold, And eventually we see where this is going, right? So there is a slippery slope. Despite what some of the theorists believe, they disagree with this. This is true. It doesn't mean you did A, you're going to commit Z. That's not what this means. There's usually an erosion, a justification, a rationalization that it's okay to move into this area. That's the slippery slope. So allowing more time, having an intense attraction, isolation. The more isolated you are, less from colleagues, increases your potential, and then excessive self-disclosure. We all have a flow in what we do, whatever our practice is. If we go and grab a chart, we look at it for a few minutes before we see a person, we walk here, whatever the flow is, we all have a flow. When we start to vary and deviate from that flow, we need to pay attention to that. And that's what this behavioral change is about. So during visits, are there behavioral changes that take place with people? That's important. So these are just some of the examples of ways to gradually interrupt the flow, bringing a drink into the session, doing things that you may not do with other people, whatever it is. I don't know what it is. Just being aware, letting people call after hours, needing consultation outside of the office. Those are all subtle, slippery slope situations to consider. All right. We'll skip that one because we'll do it at the end. However, what you think is private is not. So as much as we like to say, oh, this is private, our work is so unique and it's private, no. There are lawsuits, believe me, the public will find out, people will find out. Your organization, we already said that we all go to the sanctions section of the newsletter quarterly, right, and look it up. Actually, you can see all these online now. Any state you're moving to, you want to see any physicians, people, it's all posted online about their behavior. Grievances in the workplace can become public, where you have to sit down and meet with other people, meet with the person who has some complaint, and then obviously licensing board. That's, you know, most have a diversion program, but if you go outside of that, which a lot of these boundary problems and sexual problems in the workplace, they're gonna go outside of the diversion programs. They're not gonna monitor you. They'll monitor substance issues or something like that, but a lot of times about half of them won't even monitor boundary issues. So I already said this is fiduciary. This is work. When you go to work, work. Okay? Use work to work. That's it. That's a clear, decisive boundary. I had this thing when I was in the inpatient program where I had a set of keys in my right pocket. My personal keys would be in my right pocket. When I got to work, I put them in my left pocket, and I put my work keys in my right pocket. That was just a little signal for me. When I got out the car, then I'm at work. And at the end of the day, I did the same thing. I switched them back and waited till I got home and put them on the dresser. These are subtle rituals that you should have moving into and moving away from work, because that's what this is. It's fiduciary. There's conflicts. These are some of the conflicts. So the law, when you have a conflict, you have to do what you can to resolve it. You can't just ignore it. All right? You have to try to resolve this. The law ultimately supersedes our ethical guidelines. So, for example, I'm testifying in court. They say, did you treat this person? I said, those things are confidential. So they get the jury up, they parade them out the courtroom, the judge proceeds to get his clerk, her clerk, read the statute that says you have to disclose this, you have no ethical rights, you're in the court of law, you're expected to disclose if it's harmful to a child or a vulnerable adult. And so, yes, ma'am. The jury comes back in, and I proceed to testify for however much time. The point is, the law obviously supersedes our ethics. You get a subpoena, what do you do? All right. Let me give you a quick and dirty. Lawyers can issue subpoenas. All right? You should always respond, I received this. But you do not have to, give over your record. A judge is the only person that you have to give over your record to. And most judges, if that's what they're demanding, you can speak to them and say, can we meet in private about this? Can I give you this information? And then the attorneys will say, you can't generate another document from that. I want the raw data. There's all of that they get into. But just quick and dirty, you should respond to a subpoena, but know that unless it's from a judge, it may not require you to turn over your records.
Doesn't have to specifically say the records, because I got subpoenaed once and I showed up and got the records and where the records, you just subpoenaed me.
Yeah, I don't know. That's a good one. I would try to clarify that because I'd hate to make some of the people in the legal profession frustrated with us.
I had the same situation happen, and the only thing I took was when my client actually showed up. I didn't take anything else with me because I knew whatever I took, they could request. So I just took a list of the times that she was there and she wasn't there on a sheet of paper, and that was it. And they never asked for it. But I had that documentation saying, yeah, she did show up. And
Right. Okay.
What I did was I copied the records because they asked me to do records, but I handed the closed records to the judge.
Yeah.
And he made the recommendation that only we open it if it was being, I didn't hand it to anyone else.
Right.
So I met
That's a good job.
and then I hand them directly.
Right. Judges are reasonable people who know the sensitivity of this data. Now, lawyers are, they're in there looking for the best interests of their position. So they have a different role, a different motivation. Okay. So confidentiality, this is an ethics workshop. You got to know, confidentiality is troubling a lot of times, and you have to have permission in order to release these things. Who matters most? Well, first off, the patient and the client. Their needs come first. Then the public. Then your profession. And then look at you. You're all the way at the bottom. Just like I said, you chose this field, all right? Yeah.
Something that always concerned me was mandatory reporting.
Yeah.
When you're in a relationship and somebody slips that they had done something even 5 years ago, in my heart I know that they are a danger to children. And what are you supposed to do? I always say, anything you say, I tell them about the mandatory
Right.
reporting.
Right.
But, in a way, and part of me feels that I'm really, what about the children? What about if they are dangerous? What are you supposed to do?
Yeah, that's a really great question because, up front you should be given your breach of confidentiality, the things that you have to break confidentiality for. That being said, everybody has to come up with their own philosophy on what they're willing to do and not do, okay? Because if you're working with certain people, you can come up with a line of questions that bring a person down, a line of questioning that will obviously lead to them disclosing something, potentially, that you're going to have to report to some authority. That could be your line, or you could say, if you tell me this, then I will report it. But if you don't tell me these specific examples, then we will maintain our therapeutic process. So depends on what you want to do. If it has to do with protecting children, the Sandusky trial, which said that everybody is a mandatory reporter now, I said, in an interview, I'm not sure society's ready for that because it's conflictual enough for professionals to decide when to breach confidentiality. Somebody sees somebody jerking their child at the airport or something. I'm calling child, a lot of people are uneducated and incapable of doing that, yeah.
I'm not sure if other people in the community got this letter, but there is something that came out that's from the DOJ.
Justice.
Department of Justice, and says, there is this person that's potentially at risk. There's a picture of the perpetrator and says, based on some information, it sounds as if this person has not disclosed to their therapist these issues, but please call the DOJ if you think you're working with this person.
Yeah, that's really dangerous, and that's usurping our confidentiality, and we were based on that. Now,
Some of my colleagues said, well, no, you're not have to give confidentiality because it's an issue of child abuse. We were mandated reporters, but the letter says they have not disclosed. So again, is that law
right,
versus confidentiality and ethics?
yeah,
Frankly, I don't recommend this person.
right. But if you were seeing them in your practice, what are you going to do?
Right.
Yeah. It's more of a legal issue, somebody being turned over to the legal authorities for some crime they've committed versus your confidentiality with that person. So, you're a citizen. That's what I'll say here. You're at the bottom of this. The public safety is second here, and your professional guidelines. But, what our needs are fall at the bottom. All right, we're moving through this. So be prepared, okay? Understand the law, understand your position, decide how and when you'll limit confidentiality voluntarily, develop a plan, choose ethical consultants. We have an ethics team in our organization where when things come up, we sort of have 5 people. You have to have at least 3 people on that, reviewing that case, and then we give a disposition about how people need to respond. So, this is all part of what you can do as a group. You can form a group in a community where you say, hey, I have an ethical thing. Can you call back and we have a conference call at so-and-so time? That's, if you feel isolated and by yourself. Be upfront with people. Tell them up front the limitations and the conditions. All right. Come on. I already talked to you about gossip earlier, and that, it's detrimental, and that it seems like the person is special. It becomes increasingly likely the more you're away from the professional setting into social settings. It's impossible to defend, it's exploitive, and it's careless. That's different from a consultation. Otto, as troubled as he was seeking a consultation. Even though it was in a social setting, he got into a private area and sought a consultation. It's made profession to profession. Dudley Moore quickly said, you don't have to identify the patient. So identity of the patient is irrelevant. You don't have to. And it generates professional feelings of utility, like we're doing this collegial. We have a case here that we're discussing. Well, this is the Mississippi Code. I'm sure the Virginia Code is different, but I would invite you to read up on the child protection and the issue related to harm of self or others and vulnerable adults. So vulnerable adults, at least in Mississippi, are people who are in a residential setting. This is interesting because it differentiates from an outpatient setting. So if somebody has crossed or violated a patient's boundaries in an outpatient setting, that's not reportable. They're not considered a vulnerable adult. But we know our whole world has moved to outpatient, right? Surgeries, all these things are outpatient clinics now. So that's, to me, not a well-defined, but it's there. They have to draw the line somewhere, but that's just in the state of Mississippi. So I'd invite you to consider what is considered vulnerable adult in your state. All right, the very last 5 here. Number 21, I've recommended treatment procedures or referrals that I did not believe to be necessary in the patient's best interests. Number 22, I found myself fantasizing or daydreaming about a patient. 23, I have made exceptions for patients, scheduling, benefits, or fees because I found the patient attractive, appealing, or impressive. 24, I have made exceptions for some patients because I was afraid he or she will otherwise become extremely angry or self-destructive. I'm sorry, that was 24. 25, I have sought social contact with patients outside of scheduled clinic visits. All right, so now what I want you to do secretly is to add up your scores. If you have a never, that's a 0. If you have a rarely, that's a 1. If you have a sometimes, that's a 2. And if you have an often, that's a 3. 0, 1, 2, 3. So look at your 25 items, add them up, and pass your score to your next door neighbor. No, don't do that. Don't share. All right, I'll get something out here. I'll be right back to tell you about the scores. All right. What do people think? What do you think the cutoff is for problematic behavior? What number? 10. All right. Anybody greater than 10? No, don't say what you got, but what you think. The cutoff for like 15. All right, 15. If you got a 15 or above, there's a need to get some attention. Anybody think it's less than 10? All right. This is a normed instrument at the University of Vanderbilt. All right. Bill Swigert is a co-author of it. The cutoff is 6, the number 6. Now, it shows that if people have a 6 or higher, they need to pay attention to some of these items. So even if you did, it just means you need to pay attention to some of these items. Now, we do a boundary course. We get people in the 20s, okay, 26, 27, 28. But that's people requiring a boundary course or some kind of intensive intervention. So there's part of the assessment for you. It's just some of the limitations in rural areas. It's hard to be a friend and a doctor, a supervisor and a confidant. So I have a lot of slides for you to read through. Dual relationships are essentially unavoidable. So know yourself, know your weaknesses, be mindful of what you're feeling, what you're going through in life. Listen to that little voice in your head. Remember the pause. That little voice says, should I say? No, don't say it. All right? Know your buttons. Consult. Have a written plan. Don't seek emotional support from your patients. When in doubt about self-disclosure, don't. I just said that. No personal services. Some people have to use chaperones. Might not apply to us. Be careful with gifts. Cautious with touch. Keep records, second opinions. Use your office for work. Be willing to write it down. Don't do something you're not willing to write down. Beware of making exceptions. The one thing, I've already given you permission. You can feel a lot towards people. The one thing you should not feel is that you are special. And this person is special, and you have a special relationship. If you start to experience that, you need to seek immediate supervision and support. If you don't think you're interchangeable, it's not all about you, like was said earlier. We're interchangeable, okay? We're all vulnerable too, all of us. At some given point in time, you're human. Don't do therapy with friends, financial associates, social, organizational, family members of patients, students, supervisees, research participants, anyone you've evaluated, employees, former, current, possible future sex partners. Avoid them. As magically as a kiss can transform certain frogs into princes, a hug can change a patient into a plaintiff, a $40 motel can become a $1 million lawsuit overnight, and a hard-won career can vanish in smoke, never to reappear. Don't end up outside the tent. Is the message there? And remember, good fences make good neighbors. All right? The last thing I want to tell you is I wrote a book last year on taming disruptive behavior. This is for medical professionals who in the workplace are doing something that's disrupting the ability to deliver patient care. Okay? My colleague and I co-authored this book. And so I'm going to give a copy away. And this isn't the disruptive behavior that children exhibit that's in the DSM-5 or that you want in technology. You want a technological gadget that is disruptive, that turns the field on its head. This is the unhealthy disruptive behavior, okay? So I'm going to ask a trivia question from the book. I'll assign the book, and I'll put today's date on here. And so I'm going to ask you this question. And if you know the answer, I need you to raise your hand. Don't blurt it out. All right? And the first hand I see go up, I'll ask you to answer it. All right. What Supreme Court justice said, I know it when I see it? Yes. No. Good guess. I know it when I see it. Supreme Court justice. This is a tough one. All right. It is about pornography. It is about pornography. It was 1964. 1964. All right, I'll give you this one. It's called, his name is Potter Stewart. Potter Stewart wrote, I know it when I see it. So we use that to illustrate disruptive behavior. People often don't know what it is, so they say, I know it when I see it. It's not a well-defined topic. So, all right, so this is the one I got to give away now. All right. Who said, what famous author said, we do not deal much in fact when we are contemplating ourselves? What famous author said, we do not deal much in fact when we are contemplating ourselves? Mark Twain. There's the winner. Thank you very much for your attention. I hope you have a great day. Thank you.